Hello, everyone. Can you hear us? Can you hear me?
Yes.
Yes.
Wonderful. So I'm Pierrette. I was the one who was reaching out, and I'm together with my colleague Tyru Fopana. Tyru, can you come on camera if you can? We are going to be moderating this session, the both of us.
Great. Sorry, mine says my video is still loading, so I don't know what's going on, but hopefully it'll show up.
Okay, no worries, no problem.
Hmm. There we go. There we go.
Wonderful. We can give people like to me I think time is not off. We still have 4 minutes, 4 to 5 minutes.
We're still, yes.
Okay. So we'll just let people join and then we can start. Hi, Dr. Riviello.
Yes, I can get you.
Piret.
Hi. Good to
Since
see
you
you.
made me speak up, I'll say thank you to both Håkon and to Jackie for joining us today. I'm one of the faculty at the Harvard Program in Global Surgery and Social Change, and we're very pleased for your time with us, for sharing your insights. I'm looking forward to the discussion, Q&A, and shared uh, growing knowledge at the end of this. But we're very grateful for your time spent with us and really just blessing us with your presence. So thank you.
Thank you so much, Dr. Riviello. So I think we can start as people continue to join us. So welcome everyone. I'm Pierrette Ngutete Mukungwa. I'm a faculty at the University of Global Health Equity working within the Center for Equity in Global Surgery. I'm one of the co-moderators for this session themed the role of non-physician providers in surgery, obstetric, trauma, and anesthesia care. I'm together with my colleague Tyru. I'll let him introduce himself as well before we
Hi,
can continue.
hi everyone. My name is Tayo Fofana. I'm a surgical community health officer from Sierra Leone. Currently, I'm in Rwanda. I'm in the global surgery program. I'm a fellow currently at the Center for Equity in Global Surgery. We're happy to welcome you all here, and we look forward for a fruitful discussions.
Thank you so much, Tyru. So before I introduce the first speaker, as you can see, we have two speakers, Dr. Jackie Rolls and Håkon Angel Volkan. I hope I pronounced well your name. So before we jump in, so just a few words regarding this seminar. It's a seminar that is organized by the program Global Surgery and Social Change together with the Center for Equity in Global Surgery at the University of Global Health Equity in Rwanda. And there are seminars that are run every year, and this year we have 4 seminars. This is a second seminar, and this seminar, they basically are to explore the methods and outcomes of global surgery research. And as per each seminar, we have 2 speakers speaking on a similar topic or similar methods. And then it's followed by discussion on implication of results and methods. And then at the end, we share with the participant the video recording of the seminar. So this is the coordinating team. And Dr. Riviello already introduced himself. He's the director of the Harvard Program Global Surgery and Social Change. And Dr. Barnabas Alayande, he's the co-chair of the Center for Equity in Global Surgery. And this is me. And then other fellows that help us in the coordination include Nardos, who is also a fellow in the program Global Surgery and Social Change, and as well as the CGS, the Center for Equity in Global Surgery fellow, including Tyru, Sarah, and Alex. So our first speaker, as I mentioned, is Dr. Jackie Rolls. And Dr. Jackie Rolls is an original member of Sharon Certified Registered Nurse Anesthetist. And she's a certified registered nurse anesthetist, board certified adult nurse practitioner, and non-surgical pain management specialist. She's a well-known leader and educator in the United States and internationally for her expertise in pain management and her advocacy to increase access to surgical care. Dr. Rolls is also a sought-after speaker at nursing and interdisciplinary conferences. She's also an associate professor of professional practice and director of Advanced Pain Management Fellowship at Texas Children's University School of Nurse Anesthesia. She has played a key role in developing pain management specialty training for certified registered nurse anesthetists, including founding the first certified nurse anesthetist interventional pain management cadaver course in 2005. Launching the American Association of Nurse Anesthetists Advanced Pain Management Seminar Series, and establishing postmaster's certificate in advanced pain management in 2012 that became an accredited fellowship in 2014. And she also, this also contributed to the board certification examination in non-surgical pain management. She currently chairs an association of nurse anesthetists non-surgical pain management committee. As an Association of Nurse Anesthetists spokesperson of pain management, she has been featured in major media outlets, including New York Times, the Wall Street Journal, and USA Today. She has provided expert testimony before the Food Drug Administration, State Nursing Board, and legislative and regulatory hearings, and served on 2013-2015 National Institute of Health, Health and Human Services National Pain Strategy Team. Dr. Rolls is also a strong advocate for global nurse anesthesiology. She currently serves in her 16th term as president of International Federation of Nurse Anesthetists and she is a former president and interim CEO of American Association of Nurse Anesthesiologists. She holds several international leadership roles, including vice chair of United Nations Surge Hub Content Committee, co-chair of International Council of Nurses, Nurses Advanced Practice Nursing Health Policy Subcommittee, and member of World Federation of Societies of Anesthesiologists, Global Workforce Committee. She's also an author, contributor to several global publications on advanced practice nursing and nurse anesthesiology. Dr. Rolls is a fellow of American Academy of Nursing and has received numerous leadership and service awards, including Association of Nurse Anesthetists, Agatha Hodgkin Award for Outstanding Accomplishment, and International Federation of Nurse Anesthetists, Hermie Honor Award of Outstanding Global Leadership and Education. She was inducted into inaugural class of Fellows of American Association of Nurse Anesthesiology in 2021. She holds a Doctor of Nursing Practice from Berry University, a Master of Business Administration from Memphis State University, a Master's of Arts from University of Missouri, Kansas City, and a Bachelor of Science Nursing from Ball State University, as well as postmaster certificate as adult nurse practitioner. Outside of work, she enjoys golf, reading, travel, and spending time with her husband, daughters, and grandchildren, Sydney and Wyatt. Welcome, Dr. Rolls. The floor is yours to deliver a presentation. I will stop sharing now. Thank you.
Oh, gosh. Thank you very much. And I'm excited to be here and share some of the research that we have on nurse anesthetists, as well as actually non-physician anesthesia providers, and the role, a very important role that everyone plays in working toward access to care for surgical services. Let me see if I can get my slide up correctly. All right. Everyone see that okay? Okay, so today I'm again highlighting the global anesthesia manpower and the role of the nurse anesthetists in surgery, obstetric, trauma, anesthesia care. And I'll mention technicians too, because they are an important part of our workforce globally. Let me see if my slide, there we go. We will define who provides anesthesia worldwide, introduce the International Federation of Nurse Anesthetists, review and discuss global data collected on nurse anesthetists and technicians on 3 major publications that I see as being major. And you all, I understand, have had those publications, so I'm just going to go ahead and get started. Global nurse anesthesia providers. We have trained medical providers or trained in the medical model. We have the nurses. We, of course, have physicians, anesthesiologists, so specialty training anesthesia, as well as some physicians that are providing anesthesia without an academic specialty program. And then we have technicians. So how do we define a nurse anesthetist on the global level? We worked with the International Council of Nurses and published guidelines on the advanced practice role of the nurse anesthetist in 2021. And it was difficult, but we have agreed upon from all of our member countries, which we have 49 in IFNA now, 2 are technicians, and the other 47 are all nurses. But a nurse anesthetist is an advanced practice nurse with the knowledge, skills, and competencies to provide individualized care in anesthesia, pain management, related anesthesia services to patients across the lifespan, whose health status may range from healthy through all levels of acuity, including immediate, severe, or life-threatening illness or injury. Well, that is a mouthful, isn't it? But that really describes what nurse anesthetists are doing around the world. Historically, nurses have been administering anesthesia for over 170 years, as far as documentation tells us. The specialty began when nurses were chosen by surgeons to care for anesthetized patients soon after the discovery of ether, and the need for nurses to provide anesthesia care and related services has continued to grow throughout the years. During the late 1800s, nuns from Catholic nursing orders trained nurses as anesthetists in many countries, including Burundi, Serbia, Switzerland, and the United States. Other nurses then, outside of religious orders, were often trained by physicians. Both lay nurses and nuns who were nurses continued to administer anesthesia. During the late 19th century and into the early 20th century, in other countries, the Congo, Croatia, Ghana, Nigeria, Norway, Netherlands, Spain, Sweden, and Turkey. So you can see how the role was there, and we worked our best to try to get documentation of it. Prior to IFNA, there was really little known about the global practice of nurses in anesthesia and even accurately technicians. But IFNA and the U.S. Council on Recertification, it was called, inducted a 3-phase research study in partnership with WHO and with ICN assistants back in 1996 to 1999. And that was the first publications that we are aware of targeting this specifically. There were 193 contacts with the Ministry of Health and with nursing organizations, and 107 responded that nurses were administering anesthesia in their countries. The data included nearly stating that most all anesthesia was provided by nurses in many, many countries. We know that nurses are administering anesthesia in all resource settings in all WHO regions now, and the number of nurses is really difficult to count because we don't have good mechanisms. The spotlight on surgery really started in 2015 with the Lancet commissioned article on global surgery. Really, before that, we weren't thought in surgery as contributing as much to universal health. That was the role of primary care providers, so family practice, internists, and really didn't look at surgery. But this article said we needed better core indicators, which then would measure monitoring of safe and affordable access to surgery, trying to meet the UN resolution of 80% of the population having this access by the year 2030. Secondly, the indicator was the number of surgeons, anesthesia, and obstetricians per a population of 100,000. WFSA, or the World Federation of Society of Anesthesiologists, was advocating for 4 anesthesia physicians per 100,000 population. Research data then aligned with the demonstration of significant improvement in safe surgical care when there was 20 SAO providers per 100,000 population. And you'll see that we don't have that. Surgery, again, as I said, was kind of poorly understood and had been undervalued in terms of government funding as leading to helping with primary care. The WFSA did a workforce study back in 2017 and did data collection 2015, 2016. IFNA was not involved. The information collected came from 153 countries, and they didn't include any non-UN countries. Data collection continued or was shown to be quite difficult because there's difference in terminology or titles from country to country of who's actually administering anesthesia. And there was a non-registry of many providers, especially those that were deemed non-physician. So it was advocated that the number then of anesthesia providers should also equal the number of surgeons being trained so that we could adequately increase access to care. The terminology used in that original study talked about the trainee physician provider, the non-specialist physician provider who then jumps over and is giving anesthesia, the nurse provider at that time with either formal or informal training, and the non-physician, non-nurse, so technician training. The summary of those results were 125 countries reported physician providers, with 106 having formalized education, 77 countries with a ratio of less than 5 per 100,000, and the lowest number of physicians not unexpected to us today, were in Africa and Southeast Asia. And even when you added in non-physician providers, which I don't like that term, we can't really count non-people, but we'll talk about that. We still had 70 countries that didn't have the ideal ratio. The authors concluded basically that we needed to scale up providers so that we can increase access and meet or try to meet the resolution from the UN. Specifically, what you were interested in was an article that we published in 2019 looking at Africa, provider training and practice models, and it was a survey. We know that we had the low numbers of anesthesia providers overall in Africa, but 51 of 55 countries responded to our survey, which was started out as an internet email survey, but we needed to do phone calls to get a hold of some people and follow up. Basically, we were trying to identify who are the providers, what type of providers, of educational programs are they in, where are these providers, and what is the dissemination when we have new providers entering, even older providers, but how are we covering as best we can? Overall, there were 30 pathways identified to become an anesthesia provider, 22 programs for nurse anesthetists and/or technicians. 13 of those 22 required nursing for entry, and some programs also had physician educators as well as nurse educators. The education and practice, however, were similar among provider types despite a training variance. The survey documented that most of the anesthesia in Africa was being given by nurses or technicians. The response, though, to the survey was overwhelmingly from the physicians. And why is that? As I mentioned earlier, many countries do not have official recognition of the role for nurses or technicians as anesthesia providers and no official registry list or licensing for those roles. So if we don't have that, how can we adequately measure manpower? I want to take a look at a more contemporary study, as we look at the need for anesthesia professionals, we know that anesthesia is a key component of access to surgery, and especially in the SOTA care, so surgery, obstetrics, trauma, and anesthesia, which you see SOTA referred to many times in the literature. I want to point out one study that was published in Anesthesia and Analgesia in 2018, where this study of 137 countries, low-income countries, pointed out that access to care was actually worse than non-access to care. So that is really staggering. We always used to talk about access to care, but it needs to be access to quality care, trained providers. So in this study, they showed 5 million deaths occurred when people accessed care, but 3 million deaths occurred in people without health care. And they concluded that we didn't have good enough or well enough trained providers. And I can't think of anything worse for a patient to be in that situation or even a provider to be in that situation. So it just demonstrated we need high quality care. We embarked on an updated manpower article looking at more recently what's going on and trying to figure out what's education, what is the entry level of education, and where are people? Who's there truly? So given the developments and the need for current data, WFSA asked IFNA to partner with them on a global manpower update. So myself as president and our executive director joined or invited and joined the committee for the Global Anesthesia Workforce Survey. The survey tool was developed and UN at that time had and UN defined countries in 2020. We also included non-UN defined countries where we knew we could get some data. And it was deployed in 2021. And because of COVID, we also redeployed in 2023 to try to get new people who respond or verify numbers. So we had contacts for 172 of 193 countries. We did this all by email, 149 responses, which is a very high response rate. And we did have 6 non-UN member countries. We emailed country contacts. We asked them to help identify contacts in other countries. For IFNA, it went out to our Council of National Representatives, which is one from every country. We asked them for contacts in non-IFNA member countries, and even physicians helped us get counts of nurse anesthetists in countries. And we also had ICN help. We put everything in an online Google Doc spreadsheet, and we were all working together, especially when we got to the point of filling in information, who's the contact name and email, what was the data source. That was difficult because for physicians, there's a lot more information from governments than there are for the non-physicians. So we had to look at professional associations and registries where we had them. We collected data by physician, anesthesia provider, nurse anesthetist, or technician. Then the data was reviewed by the committee members, and countries that had greater than a 20% change from the prior study published in 2017, we contacted them and tried to figure out, was this correct? What happened? In the data correction, I did a lot of work, as did our executive director, because sometimes countries reported they were nurses and we knew they were technicians, or vice versa. So we attempted to gain missing data and also have the right category of provider. So we had 43% that reported that they had less than really a 20% change in the numbers. So we did not verify those. But as I said, over 20% we did. So there were 57% that had that greater change. We were able to re-verify 22% of that. And then we had no response to verification efforts for the rest. But we did get a report from the American Society of Anesthesiologists that they had an incorrect number reported in 2016. That was 67,000, and it should have been 47,500. So we were able to correct that, but we do know that caused a little bit of skewing of the data then back in 2017 for the USA and the Americas regions, as well as high-income countries. Global statistics results were that we had almost 670,000 total providers identified, which gave us an 8.8 per 100,000 density. So that sounds promising, right? But it's not when you look at where everyone's located. For the physician data, it was 6.6 per 100,000, and for the nurse anesthetists and technicians, it was 2.3. We had 76 countries that had less than 5 physicians per 100,000 and 66 countries overall with less than 5 when we're all counted together. Physicians' density was higher in all of the WHO regions except Africa. So this is the data per region for that study, and this study was published in 2024. So Africa, as you can see, has a very, very low density compared to all the other WHO regions, with the largest density being in Europe. If we look at the nurse anesthetist and technician data, we have almost 171,000 that was reported. And we found that nurse anesthetists are in all WHO regions. We found that technicians were reported in 4, but I know there's an error here. As we look at the regions, we see there's a lot of nurses in Africa, there's a lot in the Americas, and then less in the other regions. However, we also looked at the technicians. Now, some of this again, our data is only as good as what we could collect, but I feel like there's more than 721 technicians in Africa. The technicians in the United States did not report, even though I made attempts multiple times to get a hold of them and their association. At that time, we were estimating around 3,000 technicians in the United States. So this means non-nurses, non-healthcare backgrounds coming in, but I think there's some nurses that have done the program now. I was told a couple weeks ago there's around 4,500 now. So we know that number's wrong. Also, Southeast Asia, I'm not sure. We couldn't get a verification there. Our densities, if you look then per 100,000 in the regions, highest in the Americas, next Europe, but the density in Africa is very staggering compared to the physician density. So this is what I'm showing here in the yellow highlighted, and then how high the density is in Europe for our physicians, really, and nurse anesthetists. We looked at the densities by the income classification, by the World Bank, and we were looking at the high, middle, low income countries, obviously, as I said, had a higher physician than non-physician densities and in those certain areas. But we all know that the country classification is determined by the World Bank, and these were just figures for 2021 and 2025. In 2023, which is when we did our final verification for this survey and study, these are the countries listed as low-income countries. And I believe you all have the slides. Looking at regions, we had 36 countries report from Africa. 2 reported they had non-physician providers in 2015, but didn't report in the current. 7 reported nurse anesthetists in 2015 that didn't report in the study, the update study. Overall, there was an increase of 13,539 non-physician or nurses and technician providers, which I'm not sure we educated that many, but we had a much better counting system. In the Americas, we had 7 countries report, but we know Jamaica and Guatemala have nurse anesthetists and we couldn't get data. And we know the US had technicians but didn't report, but an overall increase of 23,650, most notably in the United States. And those I can verify were actually done and graduated from our programs. In the Eastern Mediterranean, 9 countries reported. We know we were missing Palestine because they are a program that's in our IFNA recognition for education programs globally. They were hard to get a hold of. Obviously, there was so much war and things going on, but we did hear from them more recently, but not during the time we were collecting data. They had an overall increase in that region of almost 13,000 providers. Europe. 21 countries reported, but we know there's nurse anesthetists in Austria, Germany, and Luxembourg. They're all members of the IFNA. Poland and Bosnia originally listed that they were technicians, but they have nurses. And then we had one that reported having non-physician providers in 2015, but no data current. But overall, only an increase of 7, which doesn't surprise us, I think, when we look at the data for providers. Southeast Asia, 6 countries reported. Some reported non-physician in 2015, but not in the current study. And then an overall increase of 15,279. Again, we are not educating this many people. We just have better data collection now. Eastern Mediterranean. Oh, I said that. Sorry, I went the wrong way. Okay, so data considerations. We had a significant increase in nurse and technician numbers, but I feel like it was because we didn't have a good list of key contacts earlier. And so we know that this is an imperfect study. We're unable to capture, as I said, because we don't have an official professional organization in some countries or no official recognition and licensing. This is the article published in 2024, and we actually earned the Anesthesia and Analgesia Journal's Editor's Choice Award for Best Publication in 2024. So I think that what we did was significant still. The last thing I want to quickly mention is an article published in 2019, Safe Anesthesia Care in Western Kenya. This spotlighted a KRNA training program at Kijabi Hospital, so training nurse anesthetists trying to build capacity of anesthesia providers that then were deployed to rural hospitals approved by the government in the areas of greatest need. What happened with this was it wasn't a quality study, but it didn't show a problem with outcomes, but research focused on what happens when you can give anesthesia care, basically, in these hospitals. And it showed an increase in surgical volume, anesthetic capacity, changes in the role of that nurse anesthetist, but it also was a huge economic benefit to those hospitals. They could now provide surgery, they weren't referring out, and they actually had referrals coming into the hospital, so it increased the economic status of the hospital. The nurses also had rewards because they had an increase in income, and this is, in my mind, a role model that could be used for education, training, and deployment across other low-income countries to help scale up the workforce and help our hospitals that are there. So my takeaway message, basically, anesthesia is a part of universal health. We know now that almost 1/3 of the burden of disease can be relieved with surgery. So we are helping for a healthier economy. And overall, we saw an increase in the anesthesia manpower in 2024 over the publication in 2017, but we still have work to do. We have to consider population growth. We have to consider the types of providers and how do we educate everyone appropriately. We have to develop a better data collection system and use that data to identify the specific areas we need to concentrate on for scale up and advocate for government funding to increase the funding for trained providers to strengthen surgical systems, to strengthen healthcare systems, and really have a healthier economy in the countries. Next steps, we will continue collaborations with WFSA. They have said they want IFNA to help on the next study, and IFNA will continue our advocacy efforts to get contacts in more countries, disseminate our global anesthesia guidelines from ICN because it highlights education, practice authority, what we should be doing. We want to advocate to initiate licensing and tracking systems for nurses and technicians in countries and promote anesthesia education to a full practice authority to help benefit our patients best in the community. And then include nursing in anesthesia care discussions at the country levels. So I want to say thank you for what you're doing and what we can do together to advocate for these things and ensuring that we're educated to the level that our patients need us to be to care for them, to strengthen their health and their role in their economies. I sent a bunch of references, but I think I'm slightly over my 20 minutes. Sorry about that. There's just a lot to talk about when you're talking about studies.
Thank you so much, Dr. Rawls. This was amazing. It was an amazing presentation and great work done. So I'm going to pass it over to Taiwo Fofana to introduce our second speaker. And then we will have questions at the end, but feel free to drop questions, reflections, or comments in the chat box. Thank you.
Can you share our slides?
Dr. Rawls, do you mind stop sharing?
Oh, I didn't see it. I just looked. Hold on.
Okay.
Where is my, hold on, I've lost my screen. Sorry, I'm using a new screen. Share. I'm not sharing it, I don't think.
Okay, I think now it's working.
Is it working? Okay,
Yes,
great.
yes. I hope you can see the screen. Taiwo, over to you.
Yes, our next slide. Thank you very much, Dr. Pierrett. So I'm introducing our next speaker. Our next speaker is Dr. Angel Håkon. He is a colorectal surgeon, a global health researcher, and an associate professor at the Norwegian University of Science and Technology. He's the chair for Kappa Care, a non-governmental organization focusing on strengthening surgical system and training in low and middle income countries, particularly in West Africa. His work span including surgical workforce development, tax sharing, implementation research, and health system strengthening, with a strong emphasis on national ownership and policy alignment. He has led and co-led multiple international research and educational programs, collaborating closely with ministries of health and university and professional colleges to improve access to safe surgical care. Please help me and welcome Dr. Håkon.
Thank you, Taiwo, and thank you for the invitation. Really, really a pleasure to be here and be allowed to borrow a little bit of your time and talk to you. And thank you, Jackie, for a very great introduction. And I can tell you, we only see nurse anesthetists in Sierra Leone, and totally reliable on them. So let me see if I'm able to share my screen here. That was not surprising. Do you see it now?
Yes.
Yeah. Okay. Is it in presenter mode also? No.
Not yet.
That's maybe we need to swap the. Is that better?
Okay. Yes.
Okay, very good. Good. Yes, I think I was duly introduced. I think it's good to highlight my disclosure that I'm chairman of an organization called Care, and we have been together with the Ministry of Health behind a surgical task sharing program in Sierra Leone for quite some year. And what I will do, I will talk you through more or less 15 years of our work in Sierra Leone, and going in contrast to Jackie, I think, which gives an excellent overview globally. I think we will talk more on from a country level perspective. So a little bit background on Sierra Leone, and on some reflections on task sharing / task shifting, and the papers that you asked me to highlight about is a few publications that we have done. So I will also try to put them into context of the larger work that we are doing, and take you through the development of the surgical training program, through the initiation, some resilience, consolidation, and a phase where we are now, academic integration, and then some lessons learned from this, and way forward. And I'm looking forward to the questions, and I will try to be a little bit provocative also, so we will spark off a discussion. The background of this is Sierra Leone came out of a civil war end of 90s, early 2000s, and with extreme shortage of resources, particularly human resources in the surgical field, but also on a lot of other elements. And I assume you most know what the task sharing, task shifting is, redistribution of task. And the terminology, I will say, became popular during the HIV pandemic in the 90s. But I think as we all know, this has happened throughout history. We constantly shift tasks between various cadres, and we invent new tasks. So I think it's more the framing of this that has become new. And at the end of the talk, I will try to reflect a little bit on some of the challenges also when it comes to labor market pressures for needs. What we see, at least for task sharing in surgery, that there is a lack of specialists, and then you have institutional power from the institutions that are at stake. This could be training institutions, the Ministry of Health. And then you have the implementation process around introducing a task sharing concept. And I think those are forces that come together, which I will talk about towards the end. So a little bit about Sierra Leone: 8 million people, about the size of Ireland, GDP per capita $900. I think this is 2024 data, comparable with Rwanda and US. There was a study when we started in Sierra Leone in 2010. A paper had recently came out comparing the surgical infrastructure, human resources, and activity in Sierra Leone compared to U.S. Civil War hospital during the Civil War, 1864, and you can see from both from human resources and activity, Sierra Leone was actually far poorer off than in the US 150 years or earlier. Shortly on the timeline, when we started developing task sharing in Sierra Leone together with the Ministry of Health from 2010, the Ministry of Health had introduced a free healthcare initiative, which was offering free healthcare for pregnant women and children. And we all anticipated a huge influx of deliveries in the hospitals in the country. During our time there, we faced the Ebola outbreak in West Africa, which I will tell you a little bit also. Key partners during this intervention, the Ministry of Health has been part of this from the onset, and first as the ministry, later on as a school that they developed for training physician assistants. And we have also been partnering with the United Nations Population Fund, who have also been funding this and helping out with policy. And NORAD, the Norwegian Development Corporation Agency, has taken part in this. There has been some major policies developed. There was an attempt to develop an NSOP in 2016, 2017. It didn't work out, but the last 2 years this process was taken up again, and Tyru, as one of the organizers here, was very instrumental in bringing that NSOP together, and a very important document for the country. We have done many studies, 35 studies in relation to how task sharing and introduction of task sharing has influenced or worked together with the wider surgical healthcare system in Sierra Leone. And the first study that you asked me to talk about was an early study, an observational study where we described the program in itself. We also had some safety data that it was mostly self-reported data from the trainees and the graduates in the program. They all have a logbook and they registered their operations, and they also register outcomes. But we have also done other surgical safety studies, among others, a prospective cohort study. We have also done an RCT, and we just published a 5-year follow-up of an RCT where we compared medical doctors as standard treatment of care against associate clinicians, and we could see that the result were similar, or actually the result was even better for the associate clinician compared to the standard of care. And then we have done several impact studies. So we did a baseline study in 2010 before we started. We did, after 5 years, we did a second nationwide survey. So this is our survey where we visit every facility in the country which have an operation theater, and we gather data on what is done, who is doing what they are doing, who is doing it, and so forth. And we also did that after 10 years after the introduction of this program, and that's the second paper. But there is also other papers on healthcare expenditure, on surgical needs, prevalence, household studies. We also done cost effectiveness studies, which I will not touch so much upon. So the initiation of this, it wasn't easy in the beginning to be allowed to train associate clinicians. The Surgical Society was definitely not interested. The West African College of Surgeons was not very interested, and the Surgical Society was not interested. But Sierra Leone at that time had a very forward-looking Minister of Health, a female, and she saw the need to develop access to emergency obstetric care at district hospitals. So we were able to sign an MOU to train the first 30 graduates in 2011. And at that time, we had an idea that we had this triangle, that we had CapoCare as a non-governmental organization, which developed into a Sierra Leonean organization and an international one. We have the Ministry of Health, and then we have an academic side, which is which at that time was the Norwegian University of Science and Technology. And to be able to make this a nationwide endeavor, we based on the data from the first baseline study, we knew where the hospitals where most surgeries were done and where the best capacity was. So we made agreements with 15 to 20 of those hospitals, so we could create a national training structure. So from the baseline data, as I mentioned, became very important. And what we saw there in Sierra Leone, it was done around 400 operations per 100,000 population per year. And about the same time, the Lancet Commission came out with their data, suggested 5,000 operations per 100,000, and we could have this gap that we could focus on. I think before we started, we focused on what we're doing, but we started to shift it. Well, we want to address what is not being done, and it was around 3,000 operations per year. This is a distribution of operations per 100,000 population per district in Sierra Leone, and the most active district is the Western area, where the capital is, not surprising. But we saw a 30 times difference between the lowest performing districts compared to the capital. And this is actually the same difference between the average numbers of surgical activity between Sierra Leone and the US. So there you have a double gap there. The blue bars are operations done in private non-profit hospitals. The gray bars are what is being done in governmental hospitals. So we then developed our strategy to train in the high-performing private non-profit hospitals and build capacity in governmental hospitals. And those governmental hospitals are district hospitals based in rural areas. So we were able then to. It was clearly that. Coming out of the wars in the 90s, a lot of NGOs were present, and we wanted to help strengthening the governmental sector. After some while, then this program came to 3 overall aims, and one of them was to increase surgical activities in public hospitals. Because government wanted that, and that was part of their strategy. And we also wanted to, in particular, focus on rural population to reduce inequities. And we also wanted to see if this could have an impact on maternal deaths, which Sierra Leone was among the leading in the world at that time, with more than 1,300 deaths per 100,000 deliveries, extremely high. And it was a high priority among the government of Sierra Leone. It was challenging in the beginning. Ebola came in 2014, just a few years after our first graduates had entered the system, and several of them died. Somehow it also became it also became an many of our graduates kept on working in hospitals and kept surgical departments alive during Ebola, and some were more or less constantly on call for 2 years when there was very, very few healthcare workers. And I think the amount of recognition that this newly cadre got during Ebola was important for the acceptance of this cadre overall. A little bit about the training in itself. So this is a picture from one of the graduation ceremonies. We started off with defining the curriculum according to a WHO, the surgical care at the district hospital, which the government of Sierra Leone has adopted as a key policy element. The training was for 2 years plus 1 year of internship. And we started with an interview, had a radio announcement, we did an assessment, and then our trainees was trained in modules, and each module was trained twice, and the trainees go on rotation to the partner hospitals across the country. Not need to go into that. The Ministry of Health has been part. So this is a co-work with the ministry and an NGO, and the ministry has always been having seats in the interview. They're taking part in the assessment, and some of the MOH, both surgeons and obstetricians, are trainer in the program, and they are the ones doing the examination. And they are also responsible for the internship. And upon completion of the training, when our trainees become SACHOs, Surgical Assistant Community Health Officer, then we hand them back to the Ministry of Health. So the Ministry of Health is sort of owns them then, and are giving them work assignments. The training is theoretical, it's practical, it's skills based, it's journal clubs, it's a broad variety of work and mentoring and follow up and very intensive 2 years of training. You see some pictures here, among others, a veterinary lab where we do surgery on anesthetized pigs, and skills training. These are just some pictures for the 2 first cohorts. We have now in total trained around 120, and when we started in 2010, Sierra Leone had 10 surgeons. So this is a massive contributions to the number. We have tried to focus on bringing up women into this because we believe that they are, they should have equal right. Obviously, I'm not sure if we have been very successful, but it's also partly due to the recruitment base. Maybe 15% of the cadre that we recruit from are women, but those women that have been able to go through the program has done tremendously well, I will say. So what has been the impact here? Now I'm comparing 2 of the nationwide studies that we did, the first baseline study from 2012 and the second one, or the third one from 2023, one of the papers highlighted for this, and associate clinician, as we don't like the term non-physician because you defined yourself as something you are not. I don't think that is a good terminology. So in the literature, many use associate clinician. So that is what we use here for advanced practitioners. And in 2012, this group performed 2.5% of operations in governmental hospitals. In 2023, they did 55% of all the surgical operations in the country. And you can see nearly all the growth in operations from 2012 to 2023 is due to associate clinicians entering into the program. Non-special medical doctors, which are also very active, and specialists are more or less at the same level. What about how were we able to impact equity between or inequity between urban and rural? And here we define urban as Western area because it's the most economic advanced. They have the most resources. In rural, outside Western area, rural, approximately 80% of the population lives. And the changes in volume between 2012 and 2023, you see that the additional operations done in rural areas was far higher than in urban areas. So it had an impact on inequity. And associate clinicians did in 2023, they did 55% of the operations in rural areas. So they definitely some work in the capital and rural areas, or urban areas, but it really served its purpose. So looking at cesarean section, maternal mortality rates are very difficult to measure, but volume of cesarean section is somehow a proxy indicator of emergency obstetric activities. And you can see that the associate clinician quickly became the main provider of cesarean sections in Sierra Leone, doing almost 2/3 of all the cesarean sections in the country. And Sierra Leone is a country where between 85 and 90% of the cesarean sections are an emergency cesarean section. And the cesarean section rate is still low in 2023, 5%. It should probably be around 10%. And what we could see similarity in Sierra Leone is that maternal mortality rate had a tremendous decrease with nearly 3 times the decrease over the decade, which is among the fastest decrease in Africa in this time period. And of course, many reasons come together here. The country also trained midwives. I think around 1,000 midwives entered into the system. They developed an ambulance system. But for the women to receive care, surgical obstetric care in all over the country, the associate clinician became very important to do that. So I think we can say that we conclude in the second paper that the impact of task sharing, it increased surgical activity nationwide by more than 60%. It may contributed to a shift from a non-profit sector to a governmental sector being the main driver. And we saw a shift from general surgery to obstetrics. That we can debate whether that is good or bad. It should probably be balanced. And inequity decreased. Yeah. What next for us now? We have developed a research unit in Sierra Leone, Masanga Medical Research Unit, and we have the McKinney School. We try to open up for partners across Europe, North America, universities. They come in now and use our good access to the whole country, and that we have people in nearly every hospital in the country, and we do a lot of surgical research related to this. We are also collaborating, trying to bring in surgical societies. The Dutch Surgical Society are training now within this system. Also, we have also been in talks with the Royal College of Surgeons of Ireland, who is also active. What is our lessons learned when it comes to introduction? Regulation has been a challenging part. Remuneration, salary level, and the finding and being able to stick to a clear scope of practice has been difficult to implement in policies. We have also spent a lot of time thinking of what is the best home. You need to be trained from a home institution, and an NGO is not the best home. The Ministry of Health is not the best home either. This needs to be an academic institution. This has been challenging, and we have also seen that the various phases that we have been to have had its unique challenges. What has been important in advocacy? Is it that it is 30, 40 papers that we've written, or is it the work that the graduates are doing every day in the hospital? And no doubt, it's the quality work that people are doing. It speaks for itself. But somehow it's also need to bring out the evidence. I think it's still task sharing and surgical care provided by associate clinician is still perceived by many as a second choice. And maybe it is also, maybe it's not the ideal solution, but I think at least for a country like Sierra Leone and most other low-income countries, this is the only option available for many, many decades still to come. Are we challenging the establishment? Yes, I think so. This is definitely challenging surgical associations. It's challenging other institutions also, and that is problematic. So some reflection towards the end. So this is the logo of the West African College of Surgeons, which is the regional surgical body in West Africa. They are so task sharing comes out of there is a stress on the system, and for surgery it's a shortage of specialists, and then there are labor markets dynamics that start to play out and force itself. It's not ethical not to offer any treatment either, so other solutions are pushed forward, and I think that is what we see all the time when we shift task reallocation. The role then of regulation. How do we create the legitimacy for this new group? How do we ensure professional boundaries? And how do we make sure that we create a profession and become and professionalization. For somehow the colleges is also closest it represents some kind of occupational closers, because we also want to preserve status and income, and that is also something that we need to take into account when you introduce something like this. I think task sharing these days, from what we say, so 30, 40 years ago, is a different environment that we work in now. Many countries have defined clear essential surgical packages, nearly a lot trained according to competency-based curriculums. I also think task sharing, for it to be successful, it needs to be embedded within accredited academic institutions. And formal supervision and referral networks is important, and you need to have regulatory organizations around this, and there is monitoring and evaluation. Those factors are more present today, and there is more awareness about them today, which I think makes this whole concept far safer than it was earlier. But I think the fact that surgical workforce configuration is a dynamic equilibrium shaped by the labor market pressures and institutional powers and implementation processes. And I think here is a very interesting concept which we need to dive into further. The way forward for us, the NSOP in Sierra Leone is our guiding document, and it guides what we are doing forward. It states there that surgical task sharing is something that they want to focus on still in Sierra Leone for the next 5 years, or this NSOP period. And we also we are also talking with more universities to see if we can how we can host this outside the NGO MOH structures. So for Capacare as an organization, we think it's not only training associate clinicians is important, but we are also training both non-specialist medical doctors and specialists, and we do this together with system strengthening initiatives because our overall aim is to strengthen surgical activity and make sure that patients receive better treatment. It's not task sharing per se that's just it's not the aim in itself. It's a tool. So ending with one of the Tyrus colleagues from Sierra Leone, I will say thank you, and I'm looking forward to the questions. Thank you.
Thank you very much, Dr. Håkon, for a brilliant presentation. We are now going to switch to the discussion, where we will encourage people from the floor to ask their questions in a constructive way. And Dr. P, can you share our own slides? We can keep it this way so we see who is raising up their hands, and we give them the opportunity to ask questions. You will direct the questions directly to the panelists you want them to respond. And after that, we also have a few questions should we run out of questions from the general membership that are witnessing this symposium. Thank you very much.
Tyru, we have the first question from Dr. Riviel in the chat. It's directed to Dr. Rolls, and it's asking, could you tell us more about multiple different training models your study identified globally? I think you said there were plus 20, but interestingly, graduates have similar scopes of practice, number of years of training. Who are the credentiating body, etc.? So the question is in the chat. Maybe you can reflect on that. Thank you.
Sure. So there are countries that have what I would say on-the-job training. There is hospitals that will have an educational training, and there's academic training. And we are working to increase academic training, but at the length of them, there are people in countries getting 3 months of training. and then they're thrown into the operating room or deployed somewhere because, they have a need. So there's 6 months, 3 months, a year, 2 years. It's so diverse. What we did in IFNA was come up with model curriculum for certificate, master's, and certificate, bachelor's, master's programs, and a recognition program where we look at educational programs around the world and we audit them to our curriculum and our standards, and then have a certificate of recognition, and there's different levels for that. Basically, what we're trying to do is ensure a common standard of education, but it's very difficult because there's not as many that we can reach. And then starting programs in Africa, I do get requests to help with university-based education and providing someone to lecture and start out until, that program can build its own faculty. So there's a lot of dynamics in there, a lot of different, it's not just in Africa, it's around the world that we're seeing this.
Thank you so much. Is there any other question? Please feel free to unmute yourself and just ask your question or put it in the chat. Maybe before that, I could just ask a follow-up question regarding what Dr. Riviello had asked. So, Dr. Rose, do you think countries should standardize their training programs, or should they focus on ensuring that all providers meet certain competencies, even if training pathways may differ?
Well, both. I think the way that we're going to make sure that everyone has competent training and is trained to the highest ability of what they need to operate in an emergency situation or an urgency that arises is to ensure a standard training curriculum and competency-based, as it's been talked about, in this program by both of us. But I do think there are countries that have that, not just the US, but for example, Denmark has a common training now for anesthetist program, but many don't. But yes, we are trying to get to that common training, but we have to take into consideration the resources of the country and the city, even within a country.
Thank you. I think Dr. Håkon has a follow-up on that.
Yes, I can. So we have reflected a lot about standardized training, and at least for training associate clinicians in West Africa, I think one of the key elements for it to be successful is that it needs to be context relevant. If we had a training that we were doing in Spain or in Italy, that would be very, very difficult, and I think it would actually hamper, and it's also a little bit a role of like the West African College of Surgeons who are defined the curriculum for surgeons in 17 states in West Africa. They have put the bar quite high, and it's the reality in Sierra Leone is that 2 to 3 residents are trained per year in a country of 8 million people, because the requirements to enter into the program is so difficult and so high and so costly. And that standardization, yes, it's good to stretch for, but for the really disadvantaged countries, it has become a problem, actually.
Thank you very much, Dr. Håkon. If there are no questions, I will want to follow up with one question for Dr. Håkon. The study in 2023 reveals a remarkable success in obstetric surgical cases, with up to 126% increment in the volume of cesarean section. And nearly it has quadrupled the initial baseline that you have in the first study. However, it's concerning that surgeries like general surgeries and orthopedic have remained stagnated for over this period as the study was going on. Does this reflect a deeper system failure to those particular line of services, or that surgical task shifting alone cannot absolutely fix?
Yeah, thank you for the question. Good. And I can answer the question in the chat at the same time. So what types of surgery are the associate clinicians trained to do? So they are trained to do general surgery. They typically start to learn to do hernias because it's an elective procedure. They do laparotomies. They do a vast majority of obstetric procedure. They also do some basic orthopedic skin grafting, amputations, and like a general surgeon in so a fairly broad scope. Why has general surgery and orthopedic surgery not increased in the same way as obstetric surgeries in Sierra Leone over the last decade? Well, I don't think it has anything to do with the people that are trained. Actually, it has to do with how surgery is financed. You need to pay out of pocket for most surgeries in Sierra Leone, but obstetric care is free healthcare, and costs are lower. So and there's been a priority on obstetric care. I think that is the main driving force. What is also quite interesting is that what we have seen in some of our data is that the associate clinicians, they do more obstetric care because it's free, and they do less hernia operations. And that is a contradiction, because if you think that the doctor community are the best qualified, they should do the most high risk procedures, and emergency obstetric surgeries are high-risk procedures in this case, but so that is a bit strange, and that also has to do with payment, where it's more intake generating to do hernia operations in governmental hospitals, at least.
Thank you very much.
Any questions? Okay, so if there are no comments or no question, I also have another question for Dr. Rolls. So during your presentation, you mentioned that that the benchmark for anesthesiologists, providers per 100,000 population should be 4 per 100,000 population. But I would like to ask, to what extent should the global workforce benchmark, such as the 4 anesthesiologists per 100,000 population, be considered universal, given the variation in population size, surgical burden, and health system structures across countries?
I think that we don't have really a good measure that one size doesn't fit all. I mean, WHO says 5 providers, but they're counting SOTA providers, and it was WFSA's recommendation of 4. And the problem really is, how do we get people trained and educated to the areas of greatest need? And population dependent, always, of course, but we find that in those areas, we don't have many physicians. So we've got to work on scaling up the rest of the workforce to take that. And again, that's a WHO number. It's a World Bank looks at that to say how healthy is the economy. Other than that, there's many places we're never going to meet that. It's aspirational, but we just want to be able, how do we figure out then, along with the Ministry of Health and the governments, how do we meet the needs of the population? And that's the big question, really.
Thanks so much.
Thank you very much.
Yes, Tyro.
You want to follow up? Yeah, you want to follow up?
No, Tyro, go ahead.
Yeah, thank you very much. So I am coming back to Dr. Håkon. Given that you are a co-founder of the surgical training program in Sierra Leone, which has been there for almost like 15 years now, what one thing that keeps you wake up at night surrounding this cadre, especially when you are thinking about either are they going to stay in the system for quite some time, or will we lose these people we are training to private sectors, given that the initial backdrop of this training was for district hospital? Are we going to lose them to private sector? Or is it that because of the medical legal framework it's as complex as it is now? I really want to understand what really keep you up at night as a co-founder, and what one key investment will you recommend for the government of Sierra Leone in order to ensure that you have this workforce in place for a very long time?
Thank you. Very good question. Yes, there are definitely. I have one particular element that keep me awake during night, and that is the legal protection and the support functions of this cadre. They are allowed to do what they are doing. They are supposed to be supervised by a medical doctor, and they are supervised by a medical doctor, but sometimes there is clashes here where a quite young medical doctor with 1 year of experience, he go out to a district hospital. They are there during he's doing on call in the night, and there is a SACHO with 10 years experience. And the SACHO is the one who needs to do the operations, the difficult one, and needs to be supervised by someone. And it creates some tension. And so the support functions around the SACHOs, which needs to be anchored in the registration, and that we haven't been able to develop that, although been trying, and there is it is progress towards it, but that keeps me awake. I'm not so worried about moving away from governmental sector over to the private sector, but I'm more worried about task creep, as you say, that you start to do things outside your boundaries and your skill set. I'm more worried about that, because there will be people who are more eager to earn money or to do operations instead of preserving the quality of care, and those two elements, I think. But that is also why we are so focused now on having half of the cadres, the physician assistants that are coming into the program. They are regulated under they are trained under the medical school, but the CHOs, we need to go back to Nyala, and we are starting talking with them now. Sorry, I'm getting a bit specific here, but that is an important element, yeah, to have the right home.
Thank you very much. Do we have any questions in the chat box?
None for now. Maybe in the meantime, I would also ask another question to Dr. Rose. So you highlighted in both of your papers that there is a lack of standardized terminology used to describe the nurse anesthesia providers. So why is this a challenge, and what strategies could be used to improve the clarity and the standardization of the provider classifications across countries?
That's a really good question. We did an informal survey through IFNA to our member countries back in 2021 when we started this work, and 18 different titles came out. And you could be called an anesthetic nurse. You could be called, a nurse anesthetist was the most common we found, but you could be called a clinical officer or a high anesthetic officer. The title sometimes had a very important bearing as where you were on the ladder for the governmental pay. So, you can't go in and you don't want to enforce a nurse anesthetist title or somewhere where there's a pay already higher. But it's very confusing. It's confusing for surgeons, hospital systems, the ministry. And so actually, we are working right now with the International Council of Nurses, who reached out to us. We have a nurse anesthesia expert advisory committee. We did the guidelines, in those guidelines, we use nurse anesthetists. But we're working to come up with, and this was their suggestion, the difference, very key difference between a nurse anesthetist and then an anesthetic nurse, or whatever this title is that's not educated to the full role of a nurse anesthetist. And we need nurses and technicians giving sedation and doing some things, but they felt it was very confusing right now. So that's a project we're working on, and we're in the middle of it. So that's interesting to me that you bring that up, because it's the lines blur, right? And we do need to know the difference between someone educated in the specialty and then someone that's assisting, or the way we're kind of looking at it right now has to also do with supervision. That in most countries, if you are an anesthetic nurse, you're assisting, you give medicine according to orders or a standing order where the nurse anesthetist is educated to provide an individualized, as I said earlier, but pick the right meds that are available in the country and then be able to trend, recognize, handle emergencies or things that come up. So to be able to make some decisions on your own because of your knowledge, skills, competencies, education. I hope that helps.
Thank you
so
very
much.
much.
Yes, Tyru.
Yes, Dr. Håkon, I have another interesting question for you. Given the fact that the right to operate someone, or the possibility of someone to give you the right to operate on them is like a God-given right. In ideal world, nobody should open up his or her colleague. But given the fact that you are given this opportunity, somebody has assigned a consent and agreed for you to operate them. It means that it's an opportunity that every surgeon should handle with care and should treat it as precious as it is. And research has shown that non-technical skills contribute mostly to the bad outcome comparatively to the technical skills. And in the training model of Capacia, that we don't see that much. Do you have intention of introducing non-technical skill for surgery into the training curriculum for even the graduate and those that are in?
Absolutely. No, first of all, you're absolutely right. I'm not sure if I completely agree with you that there is not non-technical skills are there. I think the way the trainees work within a community of a mixed with international specialists, local trainers, and how we talk about group dynamics, how we talk about shared decision making, how we talk about being open about your shortcomings, how discuss mortality reviews. So I think there are a lot of elements that we have at least been tried to bring in, which are non-technical skills. But you're absolutely right. It's the decision making is more important than the technical skills. And I will say that this training is as much about decision making and assessment than it is as the practical skills at all. So yes, very, very important, and it needs to be the backbone of any surgical training. And also working together with other cadres, with the nurses, with the anesthetists, is equally important. How much time we have focused on teams training, that the team is where it's that delivers. It's not the individuals, and you can be a brilliant surgeon, but it doesn't matter if you don't have the right team around you, and you are not better than the weakest part of your team. So I think that has been a message that has been important for us to convey. Yeah.
Yeah, let me just follow up with that. I do agree that the training seamlessly incorporates some of these things, but bringing it as a cause, it emphasizes it important and see how people can hone that particular skill. A lot of this you are saying, I learned them through when teachings were going on, but to have seen that this is a particular model related to this and give that important to it, I think is what something that that it's something that is worth looking into, that we can incorporate into the training.
Absolutely. I will welcome you to co-develop this together. Absolutely. Highly necessary and important. One question from the chat there: retention agreement between the government and trained associate clinician, out migration. There is out migration in terms of not moving out of the country, but there are some of the trainees or the graduates have been moved into medical school because they see that there are, I think, around 10% of those that we have trained, of the 120, they are now studying medicine, approximately. Approximately 10% has died for various reasons. Ebola, infectious diseases, road traffic accidents shows how harsh the conditions are in this part of the world. And some have also moved out to better paid position in NGOs in research. But surprisingly, I think around 80% is retained into what they are doing. But Tyro, you also you are part of this group, so you could add also. If please arrest me if I'm wrong.
So you're completely right. We still have a high retention rates, and but like you said, we still have a few people, and we're still encouraging the very young one to still pursue medicine if it is possible, so that they can as well improve their skill. Not technically to move from the training program, but we want sustainability. So we're also thinking about how do we have national trainers. So we are looking at it from that angle, that if they had additional skills and become medical doctors and possibly with specialization, then these are people that we can entrust the training into their hands in future.
Thank you.
We have another question in the chat from Dr. Barnabas. He's asking, it's directed to Dr. Rolls. From a research perspective, as this is a research-focused seminar, what was the greatest challenge or difficulty that you face in getting multi-country data? And what advice can you give to those doing this, but no opportunity to be in an international organization leadership perspective? Leadership perspective.
So the biggest challenge is really identifying a contact who can provide the information that you are requesting for your research. And often because they don't have access to that data, no one's collecting it, no one's counting it. And for us, for nurses, every country has some sort of a nursing organization, pretty much. And even if it's just the overall general nursing organization or association, we are able oftentimes to get some information from them. But you'd be surprised how many don't know what the nurses are doing in that organization or where they're practicing exactly. So that's the biggest challenge. It's establishing a contact in every country all over the world to try to get information from. And they feel bad when they can't help you, but it's just the way it is. So if you are trying to do research, is that what the question is? But you aren't in a international organization leadership perspective, maybe you're just trying to do it, for where you are, then it'd be trying to reach out to for us, nurse anesthetists to try to get information. And nurses that are doing anesthesia, I'm not sure how it's defined in the countries. In the United States, we have subspecialty and pain management certification. But when we just did a practice profile survey, which we do every 5 years, we counted anyone that was doing it 1 day a week, so 20% of your practice, because oftentimes they might move into it, but they're doing it regularly. So we counted them in our pain management survey research. So it's really, again, identifying the people, getting contacts to the people, and oftentimes getting them the survey, getting it back, which is why we had to do phone surveys some places, because the email wasn't reliable.
Thank you so much, Dr. Rolls. Dr. Håkon, do you have an addition?
Yes, if I may add, following up on the same question. We have been providing research training both for the graduates of the program, but also for medical doctors and residents and others in Sierra Leone. And when the best research are often done when this is small project, but again the best work is being done when we are able to match up an international researcher together, or like a master student or someone who wants to write a thesis together with a local who have the same and come together, do the data collection. So I will reach out to the audience here that please come back to us if you're looking for opportunities in West Africa, then we might connect you.
In
I
relation
might
to
just
that,
add too, people don't think they're doing research. You normally are doing research if you're doing any type of quality counting or statistical analysis, keeping track where you are. It's maybe a lower level than everyone's thinking, but you are doing research and can contribute.
Time.
yes, thank you very much. Dr. Håkon, in relation to that, we know there are a lot of times you have this power imbalance between HIC and LMICs. Watching for this kind of cooperation, does the Masanga Research Center currently takes that into consideration, that they thoroughly watch to ensure that those who are coming in and cooperate with the locals, there is this fair play that we don't experience the power imbalance?
Absolutely, it's important. So there is the research unit has a scientific review committee, and we are anyone who wants to do studies, they need to submit their proposal and also state who are their collaborators, and they have to have a certain amount of a fraction of local researchers on board. And we also are constantly asking for what kind of capacity development are you doing for your local coworkers? We don't want only names on the papers, but we want to see that it's shared data collection, it's shared analysis, it's shared writing. But it's not always easy, of course. Internet, poor availability of papers. There are so many challenges when you are local, that but we try.
Thank you very much.
Thank you so much. I think we have reached to the end, but we have another question arriving now. Maybe we can answer it quickly. It's directed to Dr. Rose. How did you verify at minimum, how did you verify this multi-country data? Case in point was the error you highlighted in previous 2016 data. This kind of data is sort of self-reported by country. What measures might we put in place to ensure integrity of data collected from these contacts or rigor?
Great question, and I wish I knew, but we would try to verify. And again, if we saw a number reported that was greater than 20% change from the previous survey, we didn't believe that we really educated that many more providers, so we tried to follow up. When you get it from the government or a registry, it is what you can count, right? But when you get it from a professional association, which we had to do many places, it's often maybe not as verifiable, because there's no other place for us to talk to, or that was the only contact we had. We didn't have a way of going on to a Ministry of Health website or a licensing website somewhere to check. So unfortunately, most of the time when we're really doing these manpower studies and we're looking at low resource, we're not recognized, we don't have title protection as a nurse anesthetist, using that as an example. We just have to go with the data that we have. And if we could get a second person, we tried to verify. What we had them do was write their name, their email, and what their position was, so that we could at least say, hey, this person is in the association for data. But it's very hard. It's not obviously the highest level of evidence.
Thank you so much. So we have come to the end of this seminar. We thank you so much for your time, for sharing your knowledge and the amazing work that you're doing. Tyra, do you want to say any last word? And then we pass it on to our speakers to say maybe any last word, and then we can close it.
Thank you very much for the training you've been doing in West Africa, Dr. Håkon, and also thank you, Jackie, for your work you're doing around anesthesia care. Of course, these two things are the goes together, and we definitely need them. And we are at a crossing point where Africa, to be specific, need to improve its care in order to meet the growing need. So we want to thank you for the work, and we want to thank you for giving us your time to come on this session. We watch forward for similar session that we'll have, and we'll definitely get you on board as needed. Thank you very much.
Thank you. My pleasure.
Thank you. Thank you.
Thank you. Have a good evening, great day. Bye-bye.
Bye-bye.
Thank you very much.
Bye, all. Thank you. This is wonderful.
Yeah.
Thank you so much, Dr. Riviello.
Thank you.
Bye, everyone.
Bye-bye.